Good morning, everyone. Now, Mr. McIntosh.
This morning's witness is Miss Gaynor Evans from the Case Notes Review Expert Panel, my lord.
Thank you.
Good morning.
Good morning, Miss Evans.
Good morning.
Now, as you understand, you're about to be asked questions by Mr. McIntosh, who is sitting opposite you. But before you do that, I understand you're prepared to take the oath.
Yes.
Could I ask you, sitting where you are, to raise your right hand and to repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much. Now, we've scheduled your evidence for the morning, but we'll take a break at about 11:30 for coffee. Should you wish to take a break at any other time, just give me an indication and we'll take a break. The other thing is that you need to be heard. So can I ask you maybe to speak just a little louder and possibly even slower than you would normally? We have microphones, but nevertheless, it's quite important maybe just to think about reaching the room and certainly reaching me, because my hearing is not what it was. Mr. McIntosh.
Thank you, my lord. Miss Evans, I wonder if I can take your full name.
It's Gaynor Susan Jean Evans.
Thank you. You produced two statements for the inquiry. I understand you want to make two minor corrections to your main statement.
That's right.
So I think if we could put the main statement bundle, page 11, on the screen. Sorry, page 40 on the screen, please. So this says, and you want to make a change to paragraph 11, I understand.
Yes, and there is a date of 2023, which should actually read 2013.
So you were clinical lead for IPC with NHS Improvement North of England between 2013 and 2016.
That's right.
And the second correction is in paragraph 20, which is on page 42.
That's right.
And this is about the last two words. What should it say rather than Chatham House?
It should actually say Wilton Park.
Wilton Park. And that's a Foreign Office Training Centre.
That's right.
Thank you for that. Now, you produced that statement and a supplementary statement, and are you prepared to adopt those as part of your evidence?
Yes, I am.
Thank you. What I propose to do is to not simply go through your statements or indeed the report of the Case Notes Review, but to ask you a series of questions about your role in it and certain aspects that seem relevant to the inquiry. Firstly, could you set out briefly your professional experience in infection prevention and control?
I commenced in infection prevention and control in 1997. I started in the West Midlands in the Black Country in Dudley and set up a service for infection prevention and control where there was no service previously. I worked collaboratively with the acute hospitals right next door to us. I worked across community and public health. I moved from Dudley in 2002 at the creation of what was then the Health Protection Agency and became part of the public health sector.
Within Health Protection England?
Within Health Protection Agency, and I worked there until 2010. I worked as a local infection prevention specialist working with community sector and acute. I worked with a regional office. I moved into a regional role where I worked across the whole of the West Midlands, looking at the epidemiology of bacteremia across the whole of the West Midlands, particularly then in those days it was MRSA, and we also had a big focus on Clostridium difficile in those days. From there I moved to the Strategic Health Authority. I think that was in 2009-10.
Because there are quite a large number of strategic health authorities in England.
Yes, and this was the West Midlands. So this was the Birmingham Health Authority, which then merged across and then became a tripartite across three of the areas across the Midlands. So we cover the East Midlands and West Midlands. And I was a regional lead for HCAI, reviewing HCI outbreaks of infection, serious incidents, supporting hospitals, supporting communities where there were large outbreaks, and supporting them to identify where they might have originated and what we could put into place.
What sort of outbreaks were they?
So there might have been an increase in MRSA bacteremias, for example. It might have been an extraordinary increase in the number of norovirus, and anybody that works in hospitals will know how devastating that can be over the winter period. So there might have been very lengthy or prolonged outbreaks of norovirus. It could have been any community-acquired infection. We had an outbreak, for example, in a burns unit, a Klebsiella outbreak in a neonatal unit. So it could be any of those, could be anything at all, where you think, can we add some support to the organisation to do that investigation? From that role, I then moved in 2013 into a regional role with what was then the Trust Development Authority.
So what's the Trust Development Authority?
Well, the Trust Development Authority is actually part of what is now NHS England. So there were changes in the NHS in 2013 where we had a series of changes which meant we created NHS England. We had a monitor which monitored hospitals, organisations.
Sort of regulator?
A regulator, yes. It was a regulatory organisation. And so I became a regulator in Trust Development Authority for the North of England. So I worked with organisations that were not at that point registered as foundation trusts. So they were working towards that accreditation of becoming a foundation trust.
In a sense, an inspectorate type role?
Yeah, but it was more of a supportive role. Right. So if you found that there were anomalies or standards could be raised, it wasn't just to tell them that the standards need to be raised, it was to support them to put mechanisms in place to do that. So it was a different type of supportive role. When the two organisations merged together and we became NHS England, I worked with NHS England as part of their wider, still doing the same role, but worked then within the whole aspect of the whole of the North of England with any organisation. So it could be any organisation, whether it be a foundation trust, to support them where they had challenges.
And then in 2013, you took up this role across the whole of England?
No, in 2017, I took the role in 2017 down to review in 2016, the Secretary of State for Health declared that we were going to have a gram-negative reduction programme as part of a 5-year plan. And my role in that was to work with organisations across England to reduce the number of gram-negatives. Now, in the gram-negative programme, E. coli is by far the highest rate of infections. That's what we see the most of. And most of those infections in E. coli, we know from the research that's been carried out, we know are related to urinary tract infections, hydration. We know that there are significant problems with lines and biliary, hepatobiliary infections as well. So it was to work with organisations to see how they could put improvement programmes into place. So this role, while we talk about a gram-negative reduction programme, it was actually supporting organisations as a quality improvement initiative to improve those rates of infection.
And so, looking forward, one of the features that we read in the overview report of the Case Notes Review is a discussion, which we'll come to later, about the Scottish mandatory reporting microorganisms. And am I right in thinking that some of these, the E. coli is one of those national reporting microorganisms in Scotland? I remember the person doing a transcript and they can't see you nod. So if you're going to, want to agree with me, please say yes.
Yes. That's right.
So we're going to talk about the Case Notes Review in a moment, and clearly it describes itself as a review dealing with gram-negative environmental bacteria. In your work across England on the gram-negative reduction programme, to what extent were gram-negative environmental bacteria a part of the programme?
Not huge, other than the fact that you can have environmental organisms that actually transcend both. So they can be within people, but it wasn't something that we focused on because the numbers of those were much smaller. We started with, this is the lowest hanging fruit. What can we change that's going to have a big impact quickly? So we worked with the E. coli first. Now those weren't included in the review that we undertook. So there weren't huge amounts of
So you're saying that the E. coli
environmental.
wasn't included in the Scottish review?
Yeah, it wasn't included in that because we know that it is a huge problem across the whole of the healthcare agenda. We know that is.
Before we turn to the case notes review, I suppose one question is, in your practice, perhaps the last 15 years of it that you've just described, had you ever come across a potential scenario of gram-negative environmental bacteria at the scale that this inquiry is now dealing with?
No.
Are you ever aware of that happening before at this scale?
No.
Well, we'll talk about that at the end of your evidence as well. What I'd like to do now is just focus on a few issues around the... there were 3 of you in the panel, the expert panel. And am I right in thinking that the decision-making heart of the panel of the expert of the case review is the 3 of you, Professor Stevens and Professor Wilcox?
That's right.
And in what way did you see your expertises complementary or compatible with each other? How did it all work from an expertise point of view for the 3 of you?
So Professor Stevens, his role is he is the expert in paediatrics and paediatric oncology. So in terms of patients, how you manage the patients, what would be expected from their symptoms, how you would expect them to recover, that sort of thing is his domain and his expertise. Microbiology, Professor Wilcox is the microbiologist, has great expertise in his field, expertise about the organisms, about what we're seeking, the frequency with which these organisms appear in our normal day-to-day work. Mine is with infection prevention to look at what were the practices like, what was the environment like, how did we review the environment, did we look at the environment not just from a water perspective, did we look at the cleanliness, what were the practices like at ward level, were we following the protocols that were laid out for infection prevention and control? And in the last 20 years, IPC, if I call it IPC, has actually risen in its, it's risen in popularity because we can see the benefits that this has for patients. So I'm looking at what is the quality of the care that people have delivered, and IPC is one of those indicators of quality. So I'm looking
Before we come to that process, I want to just clarify a few things about how patients and infections made it into the case notes review. And would it be a useful shorthand to refer to those patients and those infections as a cohort? Is that something you would use? How would you describe that?
Yes, we'd say the patients. Okay.
So how is it that the cohort was created? What role did you and your 2 colleagues have in the creation of the cohort you were examining?
To be fair, the cohort was actually designed and agreed from a piece of work that had been done in 2019 from Health Protection Scotland. And they had undertaken a review and created a paper, and actually it's the cohort that appeared in there seemed to be a valid group of people. That
well, let's just connect it to the document before we talk about it. So we look at bundle 7, document 5, page 214. So hopefully this is the draft, and it's helpful because it doesn't have the redactions. Is this the report that you think that the cohort's built around?
Yes.
Yes, right. So you were saying that you thought it was a useful cohort. Why was that?
It appeared, once they'd done the analysis, it appeared that the number of children that were affected, that they had identified in this cohort, were a manageable group of patients. It seemed that we agreed with their definitions of, yes, we can use these patients because we can use this group of patients because it wasn't untenable. It met within the cohort. They were within that ward sector. We were looking at a very defined area, and they were also defined by the gram-negative bacteria that their bloodstream infection had been identified. There were a few anomalies because there was an addition of another environmental organism that we added into the mix, but didn't think that was unduly. We didn't think that was unduly.
Well, let's break that down.
Okay, sorry, there's a lot in there.
Firstly, we'll pick the last point up first. What was the organism you added in?
So the one that was added in that we decided to look at as well, and we agreed, was Mycobacterium chelonae, which we looked at that, included that in the cohort.
Because that's not in the cohort that's in this paper that's on the screen at the moment.
Oh, right. So that was, and now I might then be telling you a fib then in that case, but if you could go to the first page, second one.
Probably page 217.
217, that's it. No, it's beyond that. It's after that page.
Is it the different data sets, and particularly the list on page 219?
That's it.
Yeah,
that's the one. Sorry, that's the one. So we're looking at those. So that might be an error on my part.
So which is the group that you understand became the cohort?
So I think the group that we had were the children that we identified, and they started off as a group of 85 children with 118 bacteremias across those 85 children.
Yes.
Of those 85 children, one later on, but that is the cohort that we reviewed.
Yes.
That I am confident that those ones that we reviewed, and the methodology that they used in here was how they came to agree that. Now, the three of us had little. This had been decided, as far as I'm concerned. This had been agreed when I turned up for the meeting in February 2020.
Right.
So this had been agreed that this is the cohort that we would.
So if I ask
use.
Professor Stevens, he might be able to take it back a little bit earlier than that.
He might be able to take it back because I turned up to the first meeting and this cohort had been agreed. So if I'm being a little disingenuous because I didn't have that input into the agreement into that agreement for who would be included, because I think that had already been decided when we met at that time.
Well, I'll ask him about that. But what I wanted to also, you described this cohort as manageable. What did you mean by that?
Manageable in that we're not talking about 300 people. The original time frame for this piece of work was to be 3 months.
Right.
And when you're intensively looking through case notes, they take considerable amount of time. And so to look through 85 sets of case notes in that time seemed a reasonable time frame to do that. Now, unfortunately, because COVID hit in the middle of our work,
yes,
we had a delay, and did mean that actually the amount of time we were able to dedicate to reviewing those became stretched. So we were finding ourselves needing additional resource to review some of the data that was required.
Now, one of the questions that I want to just connect this to is that there was a protocol produced, I understand. And this is, it's now in bundle 27, volume 6, but it's actually a separate PDF for the purposes of today. I wonder if we can put that on the screen. So, yes. would you have seen this protocol at the time of February 2020? No,
Yeah.
you're shaking your head. When did you see it first?
I saw it when it came to the case notes.
It came to the
When I saw it in the bundle of case notes
for
for this
hearing. Right. Okay. Well, I won't ask you about it further. I'll ask Professor Stevens about that. Now, are you able to help us what role Professor Bain played in the case notes review?
So my understanding is Professor Bain at the time was what we would call the Director of Infection Prevention and Control, or equivalent in Scotland for Glasgow. And she was a sort of conduit between the expert panel and the organisation, and also the link between the Scottish Government and the oversight group. So she was a very key player.
So you were effectively, in some senses, reporting to her?
Yes, she was an oversight. We reported actually to Fiona McQueen, but we did actually share all of the information and very open and transparent with Professor Bain.
So one of the issues that's going to, I think, arise is that, and the Health Board is concerned that they haven't seen all the material and that they have some concerns about the methodology that the review conducted. And so I'll put those concerns to each of you in turn, but just in terms of mechanics, would you be able to tell us whether, for example, the Health Board would have been given a copy of the epidemiological protocol that we've just looked at?
I wouldn't know.
No. In terms of the ultimate output from the case notes review, there's the overview report, and we know the Health Board were provided with a draft of that, and it's in the bundle. So that happened. And you've described in your statement how you looked at the draft, the three of you, and you commented on it and made changes. If we think about the methodology of the case notes review and how we should understand it, would it be fair to say that you can't, where's the actual workings of the case notes review conclusions? You've reached a conclusion, to pick one, that 30% of cases have a probable environmental connection. We can talk about what that means in a moment. But if we want to look at the detail of why you reach that conclusion in each case, where do we find that?
You would probably find that in the detail of the report we wrote back to families, which would be, we would tell you, in each of those cases, we would have told the family why we'd drawn those conclusions. It isn't in the document, as in the report that we would write, but a lot of the conclusions that you draw are based on probability, as we know, and we've quite rightly said that these are based on probability. But the workings, as in, and we do say in the report, I can't remember where, but we do say that actually it is very difficult, and there are very close assimilations between what will be a probable or a strong probable.
I want to come back to that in a moment.
Okay.
Yeah, but what I'm more concerned is finding the material, because people, we go to bundle 6 and the report itself, which is document 38, and we jump straight to page 1026. We'll see, for example, in this table, you've set out the demographic and clinical characteristics of the cases in the review. And that's an aggregate of the individuals. Am I right in thinking?
Yes.
Yes. And then if we go on further to table 4.2 on page 1028, we have the frequency of infection by organism year by year. And again, that's an aggregate of the individual cases.
So all of this information we would have had from given to us by GDC. All we've done is actually put it in a different way.
Yes.
But it would have come from GDC. All of our information on the isolates came from GDC. We asked for all of the isolates from the labs. We asked for all of the information from GDC, which was at times it was a difficult process, but that's where we got our It's all the lab data.
I'm going to come back to the method taken in a moment, but if we just go to 1043, table 5.3, this is where the three of you set out your overall conclusions, and you're nodding.
That's right.
But if we want to know why it is that 17 cases are weak possible, we'd have to read 17 individual family reports, wouldn't we?
Yes.
And if we want to know why 3 cases are strong probable, we'd have to read those 3 reports.
Yes. You could go back and look at some of the information, but this is an aggregate of all of the cases because we would have had those cases on the PTT, all of that information.
Yeah, and we'll come to the method in a moment, but from the point of view of the external reader, whether it's this inquiry, someone who downloads it from the website, or the health board, we just have the aggregate numbers in this report.
Yes.
And from our point of view, there might be some difficulty discussing that in an individual report in a public setting.
Yes.
Because there will be lots of personal data, I'm assuming.
Yes.
And it is an unfortunate reality of this cohort that a number of those children have unfortunately died since then.
Yes.
So there might be concerns of a family if we went through and discussed in detail your conclusions about their infection.
Yes.
Yes. But the consequence of that is that we can't look at your workings and say, what are you doing there? Why do you do that? Can't challenge you at a micro level. You'd agree about that?
I would agree.
Yeah.
And the whole purpose of this, we set out at the outset that none of these children in our report we would be able to identify from what we'd written. So where you have small numbers and you have perhaps one child with one infection, we set out very clearly that we would not write our report where any of the children would be able to be identified.
Except in their individual family report.
Except in their individual reports. And that's quite significant because this report that we were tasked to do was actually to work with the families as well, ask the families' opinions. We took information from the families. They asked them if they wanted to contribute anything. So we used the information in a slightly different way because we did not want this to be a trauma to families afterwards, where they could identify their own child in this. They would know because each family will know what their infection was, but it was our intention to purposely not identify anyone.
And we know, for example, that one particular family came back to you and said there's an error in respect of Microbacterium cheloni, and you made a correction. So they're obviously in a dialogue.
Yes.
Right. Do you know whether those individual 85 reports were supplied to the health board?
We sent with the families, when we spoke with the families, and we spoke to every family that wanted to speak with us after we'd published the report, and we said to them we would advise that they shared with their clinicians. It wasn't obligatory, but we asked them if they would share it with their clinicians because this was pertinent to the families. And I've no idea how many of those did actually share it with the clinicians. That was the family's information to share with the hospital at their discretion, with the health board at their discretion. But we didn't share it with them.
You didn't share?
No.
And you don't know whether the oversight board or the Scottish ministers shared it with them?
No.
With them?
No.
Okay. Now let's look at the methodology. So if we can go back to...
Sorry, just so that I'm following that question. What you said, Mr. McIntosh, was you don't know if Scottish Government or Oversight Board
shared it with the health board.
With the health board.
Yes.
Now the question assumes, and just I want to check on this, that the Scottish Government and or the Oversight Board received the 85
It's a good question.
in individual cases. Now,
so
what's the position on that?
How did the individual 85 report get to the families? Presumably you didn't email them yourself, so somebody would have done that.
No, it was done by the administrators and the administrator for our team, if I remember correctly. It was emailed directly out. It was sent directly to the families.
by your administrators.
Our administrator.
So
that
those
worked for us,
documents
as far as I'm aware.
would be in the shared drive that you were working off during the pandemic, because presumably you're all working from home.
Yes.
And we can presumably identify the administrators from your overview report because you name every member of the team. And you're not as an organization, you weren't an organization. You're not data holders for data protection purposes. Who were you working for?
Scottish Government.
Scottish Government.
And the other person who would have had an input into this would have been Professor Craig White around the communications, because there were very close links with Professor White on how we liaised with families.
But you earlier on said that you shared all your conclusions with Professor Bain.
No, Professor Bain at that point had left the organisation, was now working for Scottish Government at the end of the
So who were you sharing with everything at the end, other than Professor White? Did it be Miss McQueen or?
I can't tell you. I can't remember.
Right. But in terms of
remember.
your customer, in an administrative sense, is within the Scottish Government?
Oh, I think it was Elaine Van Hagen. I think we had a lot of dealings with her, but I couldn't swear to it was the same person.
So Elaine Van Hagen works for the Health Board?
Yes, I couldn't say in the absence of Professor Bain, because she continued to be part of the conversation, but I'm not sure who we liaised with at that time.
But what I'm trying to just check is that you describe in the report that you were instructed to carry out this work by the minister. In fact, we can see that in the report. And from your point of view as a member, and I'll ask Professor Stevens and Professor Wilcox if time allows, you would have produced your work, and you've clearly described how someone sent the individual reports to the families. Where else did the rest of your conclusions go, as far as you know?
They were all, we did actually raise this question about where did our information get stored.
Yes.
And there was a repository, I understand, a repository within Scottish Government.
We probably need to ask them, but we will do that.
I understand that was where all of our information at the end of our review was stored in their repository.
Now, given that you've mentioned Ms. Van Hagen, can you help me whether Ms. Van Hagen would have been supplied with a copy of the individual reports?
No.
You can't help me, or she wasn't?
She wasn't. Yes, sorry. They weren't given to people within, they were not supplied to people within GDC as far as I'm aware. Because she worked for the organisation, this was a discrete report, as far as I understand. Professor Stevens will be able to.
I think I need to ask Professor Stevens some more questions about it, not least of which because I'm sure some of the information is to be found in the protocol and you weren't involved in writing it. So what I want to do is to look at the methodology that you adopted and have a discussion around it. And we might go to page 1015 to do this. Because you've optimistically stated that your overall process is summarized in figure 3.2. And so I thought I'd ask you about your process. So let's just think about what you are and what you aren't, as it were, as a group.
Yeah.
What is the closest analogy that you can think of from your experience in practice or you're aware of in academia to the process that you've carried out in these cases?
So we were a group of investigators, not dissimilar to an IMT process, following the process through, using a root cause analysis to identify any risk factors, anything that contributed to any of these infections. And we're doing this on a personal level for individual cases. We're not looking at it, we're not looking at the outbreak, we're looking at individual cases as a sort of any outbreak that you are investigating. and you use the process. In this instance, they call it an incident management team. So if we're looking at all the same data, we are actually working much like an incident management team, reviewing all of the data, albeit in hindsight. We're looking at where the gaps are. We're looking at whether there's any other information that could be utilised. We're using a root cause to get to the bottom of what we might think has caused the infection. We have a hypothesis presented to us. Is there an environmental link? And so what we're looking to do is to prove or disprove the hypothesis within that investigation. We're looking particularly to see, are there harms that have come to the children? Are there adverse events that might have impacted on the care of those children and their outcomes? So when you put all of that together, we are actually doing a full investigative review of all of the care that they have had and whether or not due process was followed. Does that make sense to you?
At one level, yes, but I think we need to drill down further because this is quite an impressive process map.
Right.
So am I right in thinking that there are two sub-teams feeding in data to you, one being the HPS team and one being the PTT team?
Yes,
Now,
that's right.
We'll deal with the PTT team in a moment, but what data sources are the HPS team aggregating for you?
So we tried to look at the data that we collected from environment and the data that we collected from the laboratories. Now, the environmental data that, now if I just explain.
What we'll do is we'll do that, but I'm going to go to a page in the document that might help us understand that. So we can go to page 1088. A bit further on, sorry. We'll go to page 1095, sorry. This is your list of documents. So continue. What was the material you were looking at?
So we were looking at, we looked at all of the files for any of the environmental samples. We looked at any water samples. We looked at all of the environment. So these samples that you've got in here where it says water samples, we looked at all of those water samples that we were able to identify. We looked at, and it's not on this list, we looked at all the, we looked at maintenance records.
So that might be
for that environment.
On page 1097?
Yes. We looked at environmental audits. We looked at all of the risk management. So the HAI scribe, which is the risk management document before any building works and things take place. And we looked at, when we looked at the risk assessments are fine in one respect, but it doesn't actually tell me what work has actually been undertaken. And so what was more beneficial to us as a group was to actually look at the exact maintenance records that were undertaken in those areas. So in Ward 2A, 2B, what maintenance was undertaken. And so when we requested the data for the maintenance, there were huge numbers, I mean, very large numbers of works undertaken, and it was presented to us in a very complex way that was difficult to understand. There weren't dates, there weren't rooms attached to where the specimens or wherever. For an example, there was a blocked sink. And if I wanted to relate a blocked sink to patient A, I would expect it to say, was it in room 6? it didn't tell me it was in room 6. It tells me it was on ward 2A. Now that isn't helpful when you have so many sinks and showers or a drain or whatever it was, or a toilet. So it doesn't actually help you. So we needed somebody to help us actually refine the data so that it was in a usable form.
And this is what the HPS team
And
did.
this is what HBS were. And we had, and they did the same sort of thing, I think, in supporting us with the water specimens.
We go back to the to page 10, 15 so the HPS team are collecting together information from largely environmental sources.
Yes.
Right. There's been some confusion about the PTT team and what role it played. What were the PTT team doing?
So the PTT team looked at all of the clinical notes and they assimilated some of the data. Now we use this system because...
So what is the PTT?
That's the paediatric trigger tool.
And can we just go to page 1107 and might focus matters? Yes, so what is the PTT?
So a paediatric trigger tool is a system whereby it identifies any triggers that may present a concern for the management of that patient. And it's something that is very well known. Now, until I'd come to this review, I'd never used a paediatric trigger tool before. And in all honesty, because it's so complex and because we needed to ensure the cases that we were reviewing, so the children we were reviewing were anonymised, we used an intermediary who reviewed all of the patient's clinical notes and actually took the information from there and applied them to the paediatric.
Was the paediatric trigger tool being used to select patients for inclusion in the cohort?
No.
No. So what was it being used for?
This was being used to identify were there any triggers that would have been, were there any triggers that would have given you an indication that this person was at risk of an infection? Could you make it a little larger for me? Thank you. So if you're looking at, for example, take tissue damage or
So that's
pressure
PG2,
ulcers or things.
yeah.
Yes. So we're looking at, if we look at PG1 or 2, are there observations? Have they got a raised temperature, which could give you an indication that there is something amiss? Have they come? So any of these, a readmission to hospital within a month, that is a trigger for what's happened with this patient. It could be a risk factor. So all of these are risk factors for any, which could indicate that they were higher risk of developing an infection, and is a well-known trigger tool for paediatrics and in other areas now, I understand. It's not something I'd used before this.
But in this context, you're using it merely to have a standardised list of things to look out for.
It would, to put it very basically, it would be almost like an audit tool so that we have a consistent approach to how we review the notes. It's so that we have the same level of questioning and takes away a little bit of that bias, because we can use this as well. On the trigger tool, we've used the same questioning for each individual person.
And so does this feed into Appendix D, which is page 1109, the data synthesis template, or is that something different?
This is where we bring together all of that information. So the paediatric trigger tool, this would be the data synthesis template, would be how the data would then be presented to myself. And when I look through all of this, when I've looked through all of this information, then I say, well, actually, I need a little bit more of, need a little bit more information. So I'm just going to pick one on here, which would be on the microbiology. Why was the culture taken? So I might want a little bit more information on why was the culture taken.
But if you go down to the bottom third of this page, you'll see an entry called Pediatric Trigger Tool.
Yes.
And this would enable the trigger codes that applied to be entered in there.
That's right.
And a score on whether it was an adverse event.
That's right. Yes.
So am I right in, does it seem to be the case that the PTT tool team are consolidating, reading the medical notes, looking for things in the trigger tool, and consolidating it into this format?
That's right.
Right. So you don't know the names of any of these patients?
Absolutely not.
You just know dates and events?
I just know dates, and we identified them by a unique number which was linked to their CHI number, but
Right.
which is their hospital identifier. But
Which is their date of birth?
yeah, and we had no, all I had was a date of birth for a child and nothing else, and the episodes of infection, and we had the history of those children. So when we looked back, and although the report goes from, we were asked to look at these from 2015, May 2015 to the end of 2019, we may have had to go back before 2015 within their medical records, because we would need to know what the diagnosis was. They may have been diagnosed in 2010.
Indeed.
So we may have looked at notes that extend beyond that period.
So if we go back to page 1015, please. Would we be right in thinking that therefore the process here effectively amounted to the HPS team pulling together everything that's outside the medical notes and
Yes.
the PTT team pulling everything that's inside the medical notes into a standardized format?
Yes, essentially, yes. Yes.
And then you carry out this box which you describe as that data synthesis clinical timeline. That's the document we've just looked at.
Yes, the clinical timeline was created so that we could look at the patient journey. This is all about following the patient journey and their risk factors.
So
we
this would
look
have
at
such and such date,
Yes.
admitted such and such date, infection such and such
Absolutely.
date, right?
That's it. And you look at the risk factors and anything that could have contributed to those in the meantime. But you also look at what was in the environment in the meantime. Hence, we're looking at what happened in infection control audit. We're looking to see what the results of those were. We're looking to see, were there any particular risk factors around the environment? Did the room have a blocked shower? Did the room have a drain? Were there problems with the chilled beam? That's another issue. So we looked at all of those and brought them together in that data synthesis. And sometimes there were gaps, and we had to go back to ask further questions and for further information. But for each of those cases, for each of those children, we actually followed a clinical timeline from where they were admitted to when they became ill, to what their management was and what their outcome was.
So in the repository, not only will there be 85 individual reports for families, there'll be 85 timelines. You're nodding again.
Sorry, yes. Yes, there should be, and you should have all the data synthesis would be the data
Which is the
synthesis
form
and
we
the
just looked at.
PT, yeah, and the PTT forms, which should be.
And if we
Later.
go to page 1110, what is this document part 2 summary? Zoom in a bit, please.
Thank you. It literally is just a summary of what we've seen on the previous page. Were there any key issues that we needed to look at? The Tableau timeline is quite important because that gives us not just the infection of that individual, but we're looking to see were there any other cases that were related.
So what would you find in sort of broad terms? What would be written in a Tableau timeline? For example, a patient with Cenotrophomonas in 2018. What would you roughly see written there in broad terms?
Well, you might see this is case 3 of 8, and they started on the 1st of January, and the 8th case was on the 31st of March, and you would see where that case came in that timeline. So it could be that this was case 3 out of 8.
Right.
You would be looking along that line to say, where did it occur? What time did it occur?
Then what would the ICnet and telepath boxes be showing?
So ICnet is an infection control. I can't even think what the word is now.
Database.
We use it,
Yeah.
a database, yes, sorry. It's an infection control database that actually pulls information on certain organisms out of the laboratory, the LIMS website. So it pulls it out of the lab results. So if you've got a positive result of certain organisms, it will pull it into, every 15 minutes, it gets a refresh and it will pull that organism to say, actually, there's an alert, we have found an infection. Is there something that you need to do as an infection control team to investigate that?
And so this box would tell you whether there'd been such an alert in this case.
Yes. So it will tell you whether or not it was in ICnet. And ICnet has a prescribed list of organisms that it pulls from. Now, that's not finite, because you can actually add organisms if you have a local alert organism. When we say an alert organism, we mean something that actually within your environment is more prevalent than it is in other areas. So you can add organisms to ICnet so that it will pull them off from the laboratory. So it would trigger a response to say, actually, we've just noticed there is and it would trigger a response.
And then so similarly, the telepath entry would record what the telepath entry is for this patient.
And telepath will as well. And there is a note section, I think, within notes, which is a note section which would also record any conversations or advice a microbiologist had given, and a microbiologist had given as well.
And similarly, the IMT and PAG minutes, would that be a summary of relevant bits of IMT minutes in each case? Or?
Yes, it would be, what was relevant, what wasn't relevant, were there any recommendations, was there a decision log, were there an action log, were there any results provided, was there a PAG or an IMT?
So these sections could be quite long.
Some of them could, but usually we kept them quite short, because the others, this is just so that we could identify whether or not we needed further information. But this is just a summary of what would be on the other pages.
And then the
So was there a datex, for example?
yes.
Was it reported through the datex system? Was an adverse incident reported? So that would be yes or no.
Right. And then the environmental microbiology would tell you what was going on in the environment in terms of surveillance.
Yes. Was there any? It
Yeah.
could be were there any samples taken? Were we able to link the results? Yes or no?
Where were they?
Where were they? Yes.
And the HI scribe, where you pull the maintenance record, the HPS.
Yes, that's a risk assessment. Was there a risk assessment undertaken for any building works that were on
At the time.
At the time. Yeah.
And then there'll be other observations. Now, if we go on to the next page, which I presumably, would this conclusions document be written after you'd had your expert team meeting?
Yes. So these are after we've all gone together, and the team got together to discuss every one of the patients, and that was a minimum of twice, and some of them.
Yes, I got the impression you did it twice. Is there any particular reason why you did it twice?
Because we got some data very late on, and we had to go back. We got some data sent to us that we'd requested in December 2020, and we had to go back and review all of the cases again against some of that data that appeared in a very late submission, because it could have had an impact. So we went back and reviewed every single one again.
Now, so that means that there will be a conclusion sheet for every single of the 85
Yes.
patients. Right. So how would you respond to the criticism that your approach is subjective?
In respect of, we reviewed all of these cases in line with specific tools.
The tools being
The
structured.
tools being the paediatric trigger tool. We looked at it against their own policies, procedures of the time. We didn't go back, if we were looking at 2015, we looked at policies in place 2015 and so forth. So we tried to keep that as stable as possible. And when we're looking at like you say, some of this subjective, and it is quite difficult to make a decision around whether or not it is possible or probable or good. And sometimes that is a little bit more complex to decide. But this is all based on the evidence that we were given. This is not based on, we didn't make this up out of what we
No, but
think it could be this.
you've each got complementary expertise as you've
Absolutely.
described, and to what extent is it fair to say that effectively it's an exercise in, for each individual case, an aggregate opinion of the three of you?
It's not just the opinion, it was based on what evidence we have and on probability. And probability is very difficult to define, but it is more likely to have happened than not happened. And
Well, let's look at probability.
Just before we get to that, I think I'm clear, but when you're exploring with Ms. Evans the word subjective, what I think is established is that the material or the evidence, however one describes that you're working on is objective. There's no subjective decision as to whether a piece of evidence comes into the decision-making process. When we're using the word subjective and discussing it, that is the exercise of judgment as to what one makes of objective evidence. Sorry to be so pedestrian about this, but I want to clarify that we're at one on this.
So your position is that the process of assembling the data to produce that report that we've just looked at is assembling data that is there.
yes,
And in some cases noticing what's not there, but assembling what is there, and that is grounded in reality
yes,
as much as you can find it.
as much as you can find it.
And then once you get to the consolidated data set and the three of you are sitting on your Teams call to discuss the cases, at that point you're making a professional judgment on these issues around probability and causation that we're about to discuss. Yes. And that professional judgment is an aggregate of three people with complementary expertise.
Yes.
And so it might be that you have a discussion where one of you says, maybe this is the case, and I was, or maybe not, and you reach a conclusion by some sort of iterative process.
That's absolutely right. And there were occasions where if we were not in agreement, we would go back, look at further evidence and come back again to discuss those cases.
So when we say it's an opinion, it's not an opinion on whimsy, it's an opinion reaching opinions based on objective fact.
Yes.
Right.
On the facts that we were presented with. So and we applied the same criteria to each one of those cases. So every time we look at those, we apply the same discretion and the same critique that we would for if there was something that I didn't agree with, I don't know, in IMT notes, for example, we would go back, review that IMT notes and actually look at the interpretation of that again to make sure that actually we were all focused and on the same page before we would reach a consensus that we could put into that conclusion.
Okay, well, I'd like to move to a little discussion of probability now. We go to page 1043. You discuss, you produce your likelihood of assessments on this page. And what I wanted to do was to in fact, if you look at 1043, we see the table and we see these categorizations on the left-hand side. And you explain in this section how initially you had more categories than were usable because definite never really got used.
That's right.
Yeah. Now, this inquiry is conducted by lawyers. And so one of the consequences of lawyers is that His Lordship has adopted the approach that the test we need to apply is that of the balance of probabilities. And therefore, the view that something is more likely than not to have occurred. And if his lordship is satisfied to that standard, he can determine that it is what the facts are. Now, what I want to do is understand where that line draws in this table. And I'll ask all three of you about it. So, if we start with possible,
Right.
what does possible mean if you, in terms of whether it's more likely than not or less likely than not?
So it is possible because you can possibly relate it to there are no other risk factors that we could identify, but there could be an alternative. There could be an alternative reason for that infection, but it is possible. It is possible that it could be linked to the environment, but it could be that there is possibly an alternative.
It could, for example, have come from the patient's gut.
That we just haven't found yet.
So other things are possible in the case of possible.
Yes, it is.
Again, risk of being very pedestrian. What's the threshold for possibility? How does because we're talking about a particular case, an infection in relation to one patient.
Because there may be other cases related, other cases of the same infection at a similar time that might have occurred in a similar time within that environment. It might not be in the same room, it might be in a room further down the corridor, but it is possible, but we don't have the evidence to make a further conclusion. So we don't have a result, or we don't have a result that would link it to a specimen from a drain or a water tap or the environment or a swab. We don't have that. But we do think actually it is possible it could have come from the water. But in the absence of another hypothesis, it could have come from somewhere else. But it's possible.
Maybe I've not made my question very clear, because that answer seems to me to a different question, which is, why is it not probable?
Okay.
Now, can I start again? We're looking at 118 incidences of infection. Now, what is the threshold for a particular case to come within the broader category of possible? Because I'm assuming that one has to start with possibility before one says anything about probability. I mean, anything that you conclude is probable must also be possible.
Possible, absolutely.
So how does one get within the group, the larger group of possibility?
So if we look at that unrelated group, where we look at the unrelated cases, because there is an alternative for those 8 unrelated cases. So those we have excluded. For everybody else, we cannot exclude the environment. So if you cannot exclude it as a source of infection, they become possible.
Right. And how does one, although I may be trespassing into what Mr. Mackintosh is going to ask you, how does one exclude the environment?
So if we can find an alternative source of the infection or an alternative reason, so for some of those children, when we talk about endogenous and exogenous infections, so we're looking at infections that come from within. So for example, and we've mentioned it, so tonsillitis, which Professor Stevens probably will be able to give you a lot more detail on how these manifest. But children who have come from another hospital, for example, who have come and had healthcare outside of GDC. So they may have had healthcare delivered in another hospital or at home by another care provider. So the timing of that infection as well. So if it's not, if the infection has appeared immediately that they have been admitted, we would say, well, actually, there is a cut-off date of 48 hours. We would look at whether or not there is a 48 hours after admission. So there are some timings around it, but quite often unrelated was that these infections can be explained by other means, that maybe there has been a gut translocation of bacteria. So the infection has come from within that child. Does that make sense to you?
No doubt being very slow about this. I think
But in that case, it would not be related to the environment.
it would not be related to the environment because of the nature of the microorganism.
The nature of the microorganism, and because the child has symptoms that display that they have other reasons why it didn't come from the environment.
Right.
So does that make sense to you?
Well,
Dave?
I mean, I think that the question that's crawling to the top of my brain, and I think I need to ask, is this: are you? Please tell me if I've got this wrong. But are you effectively saying that, in some ways, possible is the default?
In some way, if it is possible, no, there has to be some sort of, is it possible that it could have come from the environment? So we have some that are unrelated.
So this is time,
but
place.
If there is, yes, time, place and person. So if you have got a reasonable suspicion of time, place and person, that actually they were in the right environment, we have some evidence that this organism existed, but we cannot connect where this came from. And there could be an alternative source of the infection.
So if we go back to the IMTs, in the IMTs quite frequently in their structure there is a discussion of hypotheses. We see, for example, hypothesis that this infection is connected to the water system and discussion about some tap or sink. Is there really any difference between a conclusion that it's possible in your work and the on the ground hypothesis generation process in the IMTs that we've read about throughout this inquiry, and that effectively someone in the IMT has gone, well, time, place, person, other infections, water testing results, hypothesis, is that not the same as possible then?
Yes. So you're looking at each one of these. Is there time, place and person? Is there a possible link between these cases? Can we possibly link those together? If there is a reason why these, in the unrelated cases, and we go on to explain why they're unrelated cases, but this is what evidence do we have? So is it possible? Because there was a lot of environmental disruption, because there were a lot of cases that appeared, and it might be that there was an organism where there were just two. I can't remember the complete details of them all now. But it is possible it could have come from the environment because we can link it to a time, place, person.
Right. So it's basic.
Link. And that is really important when we're looking at outbreak investigations, and maybe I should have said that earlier, is the time, place, person is the rationale on which we base all of our investigation.
So just sticking with possible for a moment, we'll come to the others. Please tell me if I've misunderstood. You seem to be saying that in order to reach a possible decision, you and your two colleagues, using all the data you've collected, are applying what is in essence a conventional IPC decision-making process to the data you've collected. You've reached the conclusion that it is possible there is an environmental link. You haven't excluded it because there's an obvious non-environmental connection, and therefore it is a possible. Is that roughly right?
That's right. And if that's exactly right. If it is easier to take away those, they're unrelated because we found another reason.
Yeah.
And so if there is not another reason to explain it, and we haven't got another hypothesis, we can't prove or disprove it. It is feasible it could have come from the environment.
So before we get to probable, let's just pick up strong possible, because that seems an odd piece of phraseology. Given what's the difference between strong possible and possible?
This would have been that there was a little bit more information. So we might have had, an example would be that we might have had a specimen of the same bacteria. We might have had the same bacteria, but in a different location within that ward. So if we're looking at room 6, but we've got a specimen maybe from room 3, it is possible.
It's
A stronger possible because we have slightly more information.
but it's still in the same category of conclusion as those hypotheses and the IMTs that we read about.
Yes.
Right. Let's move on to probable.
Hmm.
You explained possible and strong possible. I'm not even going to ask you what weak possible is because it seems to be self-explanatory. But strong probable, what is it that makes something from the possible to the probable?
Probably usually because there are more cases. So it might be part of a larger cluster of cases. Within a time frame, we go back to the time, place, person. So the time, place, person, there is an absence of any other risk factors that we could possibly identify. With
So, for
information
example,
we
there
had.
aren't the suggestions that are consistent with a gut translocation in that case.
No, there's nothing that would suggest that it would be linked to that. There may be some possible, microbiological results that we can link to the environment, but not necessarily to the right environment.
What do you mean by that? To a different location?
To a different location. So not maybe in that room, but maybe on the ward. Or we've had some that say ward 2 or ward 6, whichever ward we're looking at. There is a positive result, but we cannot, with a hand on heart, identify which locations that those specimens came from. So it might say ward 2, ward 2A, but actually it doesn't say which room it was from, it doesn't say which location it's from. And when you're looking to make that an absolute definite, you need something that gives you categorical evidence, a bit like probability, that says actually that specimen came from that sink on the day that that patient was in that room.
So do you need that level of precision to get to probable?
No, to get to definite, but to get to probable, what you need is that, but minus that bit of information that actually definitively links that to that environment. So we can't do that.
So you might, for example, have a time, place, person, location infection that got off the ground as possible on a particular patient in a particular room in a particular ward at a particular time. And then you add in 2 or 3 other patients in closely related time in different rooms or even the same room, but you still haven't got the sample from the sink. So you can't get to definite.
You can't say it's definite, but then you would look at that environment and say, actually, we have no other hypothesis suggested. Is it coming from the environment? But we haven't got the right level of testing to be able to prove that. But there is a strong suspicion based on the evidence of time, place, person.
And what's the difference between probable and strong probable?
Just the degree of evidence that we have. So it's probable, but if we had specimens that could link to the environment, to that area, there would be a strong probable. It wouldn't necessarily link to the patient. And I think there was one case where GDC had actually said that they could link one of the cases, but and Professor Wilcox will probably tell you more about that, we couldn't actually link it in terms of time, place, person to that individual case.
So the sample in the environment
didn't match.
Couldn't be connected to the patient.
We couldn't match it. And the reason some of this that we couldn't match is that the data, which made it more difficult, was that the data that we were given was given to us in a very, very difficult. We did use HPS to try and put it into a more manageable way of looking at the data. So some of the data was quite difficult to ascertain dates, or it wasn't filed properly, or there was for example, an IMT would say a specimen should be taken, and then we couldn't link the specimen back. So there were a lot of anomalies around data, which that is your belt and braces, and we didn't have that to be able to make
to go back to our original question about our standards of proof. On the, I think it's the next page, you have listed the actual organisms. I will go past that. You reached the conclusion. Oh, yeah, sorry, that's it. Go back to page 1044. Yes, table 5.4 and 1044. Right. You've come up with the idea of most likely. It's described in the second paragraph on page 1044. For our point of view, however, we need to focus on more likely than not, which possibly is different from most likely. If you had to draw a line, where does more likely than not come? Does it become between probable and strong probable, or does it become, sorry, possible and strong possible, or between strong possible and probable, or somewhere else? This is a translation exercise.
I think you may or may not wish to
answer that question. But look, in essence, more likely than not seems, from our point of view as lawyers, to be irrelevant.
I'll say if we're going to say that it's probable, it is possible, but we don't have enough evidence to actually make it a probable, is what we're saying. And then if it's probable, it probably did come from the environment, is what we're saying.
So it's more likely than not.
It's more likely than not.
But strong possible probably isn't in that category? Or?
No, it didn't quite reach that category because we felt we needed a little bit more information to be able to say that.
So if we go to 1043, the bright line that we're forcing you to draw, albeit you didn't draw it, sits just between strong possible and probable, and therefore places 33 episodes into more likely than not.
Yes.
Okay. Yes. We'll re-explore that with Professor Stevens, I think. What I want to do for the coffee break, also to point out to my colleagues, someone hasn't changed the clock across the other side of the room, so I'm now anxious that it's 12:20, but it isn't.
Well, if you look to your right, you'll get more reassurance.
Thank you, my lord. What I want to do is to let's talk about root cause analysis before the coffee break. So, in your statement on page 45, paragraph 36, you discuss page 45, please. Not the supplementary statement, that's the original one, yes, 45. There we are. Bottom of the page, paragraph 36. You discuss root cause analysis, and you make an observation that this was instigated in late 19 as a methodology. I want to just check that you've seen a document that we've been looking at, which is Bundle 4, document 45, page 190. I think from the index sheet it might be something you've seen. This report on the root cause analysis of 13 cases from 12 paediatric patients.
Yes, I saw this for the first time earlier this week, but this is an SBAR based on a culmination of the author analysing root cause analysis for these cases. However, I've got some reservations about...
But before you do that, I just need to connect documents together. So can we look at Bundle 6, page 1100? Bottom of the page, root cause analysis. So these three subjects on the bottom of the page, root cause analysis, there's 3 entries. This analysis here isn't the document we've just shown you.
No.
No. And so the document, is that a summary of it, or it reads like that?
That paper is a summary written in...
Back to Bundle 4, please.
It's a summary written in the format of what we call an SBAR.
Yes.
Situation background, so on. So this is a culmination of what people have found in using the root cause analysis to investigate the cases. Now, the root cause analysis, this, if we go to the bottom of the page, if you wouldn't mind, on the bottom of the, oh, sorry, the next page. If you go to the bottom of the page here, and it does say that in the methodology here, the root cause analysis was taken. The root cause analysis was taken, but somewhere in this, and it may be that piece has been redacted, but it does say what this is a conclusion rather than, I don't know, is there another page following this?
There is.
That's it. Thank you. It gives a conclusion that says it's not identified a single environmental source. However, further back, it does say that actually there hasn't been an input to the root cause analysis, either by a microbiologist or by the clinical team. So in effect, what you've got is a conclusion of these 12 RCAs, but actually the RCAs haven't been completed because there hasn't been a clinical input.
So if we can just try and do this by analogy, you've described you carrying out a root cause analysis. Your root cause analysis was carried out by, I hope you don't mind, an infection control nurse, a microbiologist, and a treating clinician.
Yes.
And this root cause analysis was carried out by an infection control nurse.
Yes,
Seemingly.
whoever, well, I don't know who the author
No,
of,
but
of this was.
they're professional, they're on your line of professional skills, not
They are,
microbiologists.
but you're making an analysis without all of the information. You haven't had a clinical input to the RCA. You haven't had a microbiology input to the RCA. An RCA is only as valuable if you've got all the right people making those decisions around the table. When we looked at undertaking our root cause analysis, we went away and found that information, and we went out and found additional information that we needed. Now, there is no clinical input into this. This is an appraisal, and it just says the review has not identified a single environmental source. That's fine. But where is the recommendation out of
I
this?
think the then lead or acting lead ICD, Professor Leonard, would, I hope I'm not putting words in his mouth, would probably observe at this point that when the decision was made soon after this was done, to declare Ward 6A microbiologically safe, the sources of information comprised this, the root cause analysis this is summarizing, his reports to the IMT about various matters, including his views on some of the whole genome sequencing that was being done, and epidemiology presentation produced by, I think, Dr. Kennedy, and the HPS 2019 October paper, which we've already looked at, and that all of those together, along with some work from Professor Jones, were fed together to the IMT that reached the conclusion. So does that render it unnecessary for there to be, at this stage in the process, an input from a clinician and a microbiologist? Because you'll get that in the IMT.
Yeah, but it actually says that the RCA should have that input, and it isn't there. And that might have an impact on what a clinician might think is a risk factor or could have contributed to those infections. My other concern about these, while we haven't identified a single environmental source, is that the infections that you have are not common infections. And still, we go back to what is the source of these common infections.
That might be a useful topic to wrap up before the coffee break. We've heard a lot of discussion about the concept of unusual microorganisms. Now, in the context of gram-negative bacteria alone, what should we understand, or what should we think of as important about the concept of an unusual microorganism from your point of view?
It's whether or not it occurs frequently, whether we see this as a common source of an infection, which we don't see, and Professor Wilcox would be best to advise you on the numbers. That's his bread and butter every day, about how frequently they come through. All I can tell you is that some of these infections I've not seen in my career as a source of infection, in a bloodstream infection, in my infection prevention career.
We've had some discussion, I think I might have to ask Professor Wilcox, I'm not sure how I'm going to fit it in, but I'll try, about whether some of these infections do or do not have background rates. Is that something that you would be familiar with as a broad concept, even I'm not going to ask you about individual organisms?
Yes, yes, and background rates, we do see some background rate of infection. And I think sometimes we look at background rates of infection and get a little bit complacent, because a background rate of infection should actually be looking to reduce a background rate of infection all of the time. We shouldn't be complacent and just accept that that is the background rate. And this is why we use quality improvement infection prevention, is that you should be striving to reduce the numbers of that background infection, not accept that that's the norm.
And how does that apply in the context of a microorganism that you might only see at least 5 people have said once in a career?
Well, you might see one. It is exactly some of these I had to ask about because I'd never come across these before. And if you get a novel organism, is how we would describe it, that it's novel, we've not seen it before, or it should ring some alarm bells as to say, where has this come from? Is it something new? Have we seen it before? When was the last time we saw this? And I think there were some infections, looking at the data, that they'd only had 5 in the whole year previously in the whole of Scotland, and yet we'd had 3 infections of the same organism in a very short period of time. And I should ring alarm bells with the team.
Is it reasonable? I'll put something to you, so I'll set this up, which is that it's been suggested that in the second half of 2019, the rates of potentially environmental gram-negative bacteria taken as an aggregate were comparable to the rates in the previous building for the move, or in the early parts of the operation of the hospital in 15 and 16, and that some reassurance can be derived from that. There is a contrary view expressed that these are unusual microorganisms, they're very rare, and one should be very, very alert about that. Is it legitimate to look at the overall rates of gram-negative, potentially environmental bacteria, when within that group there are some very unusual organisms?
I think you have to, my opinion would be that you look at the very unusual cases of infection. Rates of infection in the old hospital, this is an old building with a worn environment that brings with it itself challenges. When the building can't be kept clean for one reason or another. So you do get some level of infection. When you move to a brand new build, which should be built to a specification that is all whistles and bells, so that you design out faults that you've experienced before, you would hope to see that you would a decline in your infections overall. Now, we are dealing here with a susceptible cohort of children who are very vulnerable to infection, and we'll pick those up. But I do think that the novel infections that we've seen, the very rare, unusual infections, do warrant investigation and should be treated with that. And where have we got this from? It's a really unusual situation to be in, because it's not just one, it's several.
Thank you. I'm going to suggest, Paul, that we take our coffee break now. I'm going to see what extra questions, see if there's any informal rule 9s in the room at the moment. And I'll pick them up after the coffee break, but this might be a good time to break.
Right. As I said, we'll take a coffee break. Could I ask you to be back for about 10 to 12?
Thank you.
Ms. McIntosh.
Thank you, Laura. I wonder if we could just pick up something about the root cause analysis. Ms. Devine, who's currently the Director of IPC for NHS Greater Glasgow, explained in her transcript, just for the benefit of colleagues, paragraph 458 of her statement, that what was done in October 2019 was more of a clinical review rather than a root cause analysis. What would you understand by that distinction, if there is one?
A clinical review would be reviewing all of the medical notes. I would anticipate the nursing notes, the medical notes, whereas a root cause analysis is actually the questioning. So I would be asking the question, why did we do this? Why did this happen? So I'll give, if it's all right, I'll give an example of a root cause analysis from a line infection. So when you're looking at that, why did that person get a line infection? And because it wasn't inserted correctly. Why wasn't it inserted correctly? Because the clinician doing the insertion hadn't been trained. Why hadn't it been trained? Because we don't have a training program for doctors. We only have a training program for nurses. This is hypothetical. Why don't you? Because their training comes from a different department. And then when you get to the why, so you go and say, what's your recommendation? Your recommendation is that you implement a training program that crosses across all genders. So it's a different process from just reviewing the clinical.
It's an iterative process of asking questions.
It is. It's actually a device. It's an in-depth, and usually, to put it simply, it's a series of questions. You ask why. So the 5 whys is generally accepted as why did this happen? Why didn't that happen? Or it's a series of questions till you get to the very bottom of your reasoning.
Whereas a clinical review wouldn't necessarily have that.
No, it would say, well, these are the notes. And you might ask the question, well, why we did that? But you're just reviewing a series of records rather than challenging. You could add some challenge in there. There may be some challenge in there, but you're challenging those records. But are you asking the right question if you're not asking about the environment? So if you're just looking at the clinical records, what are you learning about your environment? What are you learning about your IPC audits that might have contributed to that situation, whatever it is?
I want to show you the list of Sorry, that shouldn't have happened. I wonder if you could look at the list of microorganisms at table 4.2. So that's page 1028 of bundle 6. Since you gave some evidence about things being unusual, I thought what we might do is look at the list in table 4.2 on page 1028 of bundle 6 and ask you to identify which of these organisms, albeit I accept this is by genus, are either in of themselves novel and that you would rarely see them, the way you just described, or where some of the species within there are novel or unusual. So which are the ones that where the whole genus is?
Okay,
is
I wouldn't have come across a chromobacter.
Right.
I wouldn't have come across. Well, maybe I have Chrysiobacterium. I have maybe come across that one, but it's not a common one that I would have come across. Aeromonas, certainly Elizabeth Kingia, Delftia.
So Aeromonas, Elizabeth Kingia, Delftia, Chromonobacter, you're seeing as novel.
Yeah, and the one at the bottom, I have not come across those.
Herbaspirillum.
Yes.
And if we go on to the next page, of the list on page 29, which of those would you see as something that you in your practice would either rarely or not come across?
Can't even say it now. Rolletella.
Right.
And Rhizobium, Roseomonas, and Sphingomonas out of that table.
And if we look at the organism at species level, can you help? It's a long list, I appreciate that, but I think it's worth doing. Of the organisms listed at species level, which ones have you, until you got involved in this, not come across?
Acromiobacter. Acinetobacter I've come across before, but whether it was Bomani, I don't know. I couldn't tell you that. Certainly that Acinetobacter Yersingi, I've not come across that before. Brevundiomonas, I've not come across that one before.
Now, those ones you've just discussed, would they be in your ideas of your definition of a novel?
There would be, well, I would need to know a little bit more whether or not we'd come across those before as an organisation, to say, is it novel? Because there are some situations where you would find those, but they're not ones that I have come across in my experience before.
And just is that a sort of level of creating a level of alertness when you see?
Well, it does. If you find something, you think, oh, I don't even know how to pronounce that. That's really unusual. And I think what stuck in my mind was the Elizabeth Kingia one, because I had never come across that one before.
So just stick with the list. You were at Brevundiomonas.
Yep, I'd never heard of that before.
And what about the last four on that page?
I saw Citrobacter I've come across before. Chrysobacterium I might have come across, but in terms of the species, I couldn't tell you which species. I would tend to remember the first part.
And over the page, the long list. So maybe it's just anything here that is complete. Oh, you mentioned Elizabeth King, but anything else here that's you would categorise as novel in the way your evidence?
I think because Citrobacter we would heard of, but there are so many. Look at all of the different species. Now that would to me give me why have I got all of those? That's unusual. We have 2 Elizabeth Kingias. That would be unusual to me to see 2. So 2 different ones where it's a rare organism anyway. And now I see there are 2 different species. Why would that happen? It would make me curious as to why they were there.
So really the point you wanted to get across is that this creates a sense of curiosity.
Yes, and that's I would go and say, well, where's that come from? Or why have we got that? Where do I get that from? It would make me go and search that out as to why.
And is there anything else on this page that is in a similar category?
So the Herbaspilium. Let's have a look further down. Rotella, the last 4, I think, the Rosomonas, and Serratia. I've not come across the liquefans before. That doesn't mean to say it doesn't, it isn't common. I've just not personally come across that.
And then the last page, assuming that.
And Spingomonas.
Paracelia immobilis.
Yeah.
Right.
The Stenomona I've come across before.
Yes. And
Serratia I've come across, yeah.
So what we take from this is that when you meet things that are unusual, you should be asking questions.
I would ask the question. I would want to know. It would trigger a curiosity in me to want to know, where's that from?
Now, if we can take that document off the screen and look at bundle 7, page 267, which is the 2019 HPS report we were looking at. So this is in a section of that October 2019 HPS report we looked at the very beginning. And you see, presumably you read this at the time?
Mm-hmm.
You see the comparison with other health boards section?
Yes.
And we have here in the first paragraph, when comparing the overall rate of positive blood cultures since the move to RHC to the combined rate of the other two Scottish Children's Hospital, Aberdeen and Edinburgh, the incidence of positive blood cultures using the case definitions 2 to 5 was higher in the Children's Hospital for environmental, including enteric group, but lower in the gram-positive group, and no difference in the gram-negative group or the environmental group. This is something that I get the impression that some of the witnesses think is rather important. It's a source of reassurance. And if we look at the actual report of the case notes review, paragraph 8.2.3, which is page 1068. Sorry, of bundle 6. You discuss this data. And I think you've explained in your statement that this arose partly in response to comments from Greater Glasgow in response to the draft of the report. Is that, have I put the document 2 and 2 together and connected the right documents to the right section?
I think so. Which paragraph are you referring to?
The description is in the middle. So, second paragraph, we had not intended to provide a critique of this report.
That's right.
However, its significance loomed large in our discussion with NHS Greater Glasgow, and we therefore added this short section summarising our view of the report's findings.
That's right.
And then the second paragraph from the bottom, we do not see that this report would have provided any clear message or either reassurance or concern about past events, nor do we see it to offer a clearly interpretable and favourable comparison with other Scottish children's hospitals.
Yes, I do.
Remember this?
Yes, I do remember it. Yes. Yes, and that is right. And what concerns me personally about the report from 2019, and there does seem to have been some store set on the results of that report from 2019 by GGC, and there was a great deal of conversation regarding the relevance of that report to the organisation. I alluded to it a little bit earlier that I am always a little bit wary of trying to justify your levels of infection, which is what it feels like.
So that particular...
In that particular thing. When the argument is that if you are looking at, are we the same as everybody else? And there is some store to say, are we the same as everybody else? What I struggle with in this report is actually the merging of two organisations to make the same amount of data, to make it the same as...
so in the HPS report, they merged the two.
They merged the two.
If we can go back to bundle 7.
And that, to me, isn't the same as looking at a different hospital, which would have similar, a children's hospital, which would have similar demographics. So if I wanted to look at a hospital, I wouldn't take two small ones and put them together because the demographics are different. The procedures that they undertake could be different. Now, I don't know these hospitals, but that's my interpretation. I would want to look at a hospital that had similar demographics, had the similar number of children going through. So I might look at a hospital as a comparator, a hospital in another area. If there isn't one in Scotland, you'd have to look further afield around the UK. And I would want to be looking at, are there several, not just one, but what is it, where do you sit in amongst your peers, rather than, which is what I think the intention was, but when you put the two groups together to make one set of data, that's not really the way that I would have approached it. Now, I'm not an epidemiologist, but I certainly wouldn't have approached it that way. And I do think that when we looked at those, what it seems to suggest is that we're no worse than anywhere else. But actually, is that what you want to achieve, being no worse, or do you want to strive to be better?
So you're not an epidemiologist. There wasn't actually an epidemiologist on the...
Excuse me, Mr. Magendorf, just that I'm keeping up. One point is your use of the word demographic. What do you mean by demographic?
So the same type of children who would have the same type of procedures, similar numbers, similar types of treatments that they would treat. So children's hospital.
Similarity of the patient
Absolutely.
cohort,
as
yes, opposed to
as
the wider population from
yes.
which these patients are drawn.
That's right. Because the environment from which they're drawn, they come from all over Scotland to the hospital, and the same that you would in a specialist hospital in London, Birmingham, Newcastle. They would come from anywhere.
Thank you. Sorry, Ms. Mason.
It would just to note, you're not an epidemiologist. There wasn't actually an epidemiologist in the expert panel, was there?
No, there wasn't.
How do you respond to the criticism that a flaw in the work of the Case Notes Review is it didn't carry out its own epidemiological comparison with alternative hospitals?
The review was never intended to be an analytical study. There had already been several analytical studies, and the organisation has its own people who are quite capable of pulling together an epidemiological study, and they were supported by HPS. So what we were asked to do, and I think this is in the document, which is the protocol, which says that it should have been, I can't remember the word, but something like a descriptive study rather than an analytical study. It doesn't say, it says it does say that it should have been a descriptive study. This is the first study that have focused on patients, the children and the families. And we included those families in that discussion and wanted to hear what their concerns were, that we could address that through reviewing those clinical records. And it was a descriptive study. I think it says descriptive, but it was a descriptive study.
Now, I want to move on to the issue you raise in paragraph 42, page 47 of your statement. This is about alert organisms. And you make this statement, which is, I suppose, a little bit more crisp than some of the discussion in the actual overview report, that you appear to have understood there was no verbal communication or regular meetings between IPCs and microbiologists because of a prior complaint. And we have her letter, Ms. Grant's letter of the 1st of March, in bundle 25, document 3, page 151. And I really just wanted to understand which bit of the letter you're referring to, because so if we just look at this letter of the 1st of March.
It may be the second that I made a mistake. Can you go to the next page, please?
Next page.
Next letter.
Next page. You see in the middle there's some metallic text?
Yes, that's it. That's the place.
So this is the paragraph after, we are of course unable to see this evidence.
Yes, and we didn't see the evidence of what had happened. We were just aware that a situation had arisen. But speaking to the infection prevention team, and I did that as part of my information gathering about their processes and how they worked, it was very clear that there was a disparity between infection control nursing team and the microbiology team. And that had been going on for some time, and there was very little. So they said that they get their information.
So who's they in this context?
Sorry, the infection prevention nursing team.
Yeah.
They gather their information, and either it comes through ICnet, and we did hear that there is an email address where information is passed between, but because of an altercation, for want of a better word, with microbiologists at that time, there was no direct communication or very little direct communication. And we do understand, and we think we wrote this in the report, that we have seen an email which actually discourages that conversation between the two.
Yeah, so I just wanted to, obviously we've spoken to a lot of the people that you would have spoken to. But I really need to understand whether you've seen more than us, as it were. So obviously you've had conversations with infection control nurses and microbiologists. You're nodding.
Yes, we have, sorry.
And this particular paragraph seems to make reference to a issue about the Royal College of Nursing being involved. Now we've had evidence of that happening in 2015, but putting that aside for a moment, is that your only source of evidence about this particular thing?
As far as I have seen, but I understand that Professor Stevens has seen correspondence.
Well, we'll talk to Professor Stevens about that. But from your point of view, the only evidence about this particular process or disagreement is in that paragraph.
It's from that paragraph, but also in the conversations.
In the conversation.
In the conversations.
And now you, were you involved in the meeting where you met Dr. Peters and Dr. Inkster?
Yes.
Yes. Any particular reason that it took place quite late in your processes?
Not that I'm aware. Not that I'm aware there was any reason why it was so late. We spoke to other microbiologists, but I couldn't tell you why it was late in the day.
I want to go back to your statement to page 65, paragraph 108. Where you're discussing the meeting that you had with Greater Glasgow Paris, page 65. Thank you. A telephone call.
Yes. Yes.
With Ms. Grant, Dr. Armstrong, Dr. Davidson, Mr. Edwards, and Ms. Van Hagen. Now, from your point of view as the people who are hearing what concerns they have, what were the expectations of Greater Glasgow that they were trying to communicate to you that hadn't been resolved?
What they were unhappy with, having given us a lengthy, I think in excess of 60 pages, amendments that they thought were errors or things to be adjusted in the draft report. When we had the conversation, this was about, and I'm going to be frank, this was about actually how this makes the organisation look bad, as though we didn't do anything, which is not strictly what the impression that we thought we were giving, but actually what they wanted was, so it felt like, to dictate what we wrote in that report. And it felt we pushed back several times, to be fair, it was Professor Stevens who did most of the talking on that conversation. I haven't got, the only notes I have are the notes that I took at the time. But there was a conversation that was decidedly uncomfortable, that they vociferously disagreed with information that we had put into the report.
They also seem to have an issue with methodology. If we can go to the next page, page 66, paragraph 111. You say that criticism of your methodology could have been raised earlier in the review as a point of concern. Now, how could they have been raised? Who did you discuss your methodology with before you got going? Well,
at the point where the methodology was being agreed, back in February 2020, when Marion Bain was part of that conversation, and Marion Bain was the conduit between the two, there was opportunity then for conversation to come back. So actually, we disagree with this style of methodology. And Professor Stevens, I'm sure, will tell you a little bit more, but he met on a regular basis, either by phone, majority of the time because COVID had hit, with the clinical teams to explain.
So when you say the clinical teams, do you mean the paediatric oncology teams?
I do, yes. The paediatric oncologists, and that would be the clinicians, the nursing team, anybody else that wanted to be included. And some of those meetings also included a senior member of the core project team. So that could have been Marion Bain. It could have been, I can't say for definite, but it could have been somebody like Craig White. But somebody else could have been a part of those conversations. So there was opportunity for those concerns to be raised either by those clinical teams or fed back earlier in that conversation.
I mean, I wondered whether there's something here in that the people you've mentioned are either the treating clinicians and nurses in the ward, or they are people actually brought in by the Scottish Government, because Professor Bain and Professor White are Scottish Government people.
But Professor Bain wasn't at the beginning, was she? She was still employed by GGC when we started the conversation.
That's your understanding? That's
my understanding, is that because she was the Director of Infection Prevention and Control at the time.
She wasn't brought in by the Oversight Board?
She was part of the oversight board, but
Yeah.
she was representing GGC, as my understanding, at the beginning. During the period of our investigation, she did change roles
Right.
and went to work for
Okay.
Scottish.
I'd like to take you to the executive summary of the report. That's bundle 6, page 982. I'm going to this because it just seems quicker to do this. To the second bullet point, the one that begins ICnet. And you see in the middle of this paragraph, you discuss the National Invention and Prevention Control Manual, the minimum nationally agreed minimum list of alert organisms. You see that?
Yes.
And then you will quote the guidance saying the list is not exhaustive, which you've already mentioned.
Yes.
And then from 5 lines from the bottom, we go, we have found little evidence, even as late as 2019, that, and despite assurance from NHSGC, the alert list has been modified in light of the evolving experience of GNE bacteremius. This resulted in frequent absence of alerts being triggered with ICnet and subsequent absence of IPCT input in some episodes of the GNE bacteremia we reviewed. Now, I just wondered, firstly, when you say evidence, would you have been looking at the actual changes in ICnet itself?
No, we were looking to see, so there were some organisms that they said had been added in 2018.
Yes.
And yet in 2019, when these organisms are found, they do not elicit an alert in ICnet. So either the alert has been added but not activated correctly, or it was not added.
Or it was added and taken out?
Or it was added and taken out, either, yes.
And do we see example at page 1072 of bundle 6?
Yes, I think we did see the one, we did stipulate that as an example, yes.
Yeah. So you're not basing this on, how can I put it, close questioning of the relevant people. This is an inference drawn from the data that you've been given.
Yes, this is the data. We had somebody interrogating, for want of a better word, ICnet.
Yes.
For episodes of infection, and that person, and they were not available to us.
Okay.
It hadn't created an alert.
Now, if we go back to your statement to page 48, you make various criticisms, I think, of the incident management team process within paragraphs 43 to 47. Wouldn't that be a fair summary of that section in part? Or?
Yes.
Yeah. To what extent is this a criticism of either the organisation of NHS Glasgow or individuals within it, or both, or neither?
I think this is a criticism of process.
Right.
So when we looked at the process of the IMT, and sometimes, without going through this in extreme detail, when we looked at the process, so the process would be to, if you are concerned that there may be an incident, we have 2 or more cases, time, place, person, we look at a problem assessment group, the PAG, which we've heard about, and then we undertake in there a risk assessment. So is there a risk assessment, and that risk assessment will say, do we then go on to instigate an incident management team to investigate what we think could possibly be an outbreak? And my concern is, once you've got that, so some of the incident management teams don't take place for quite some time after, and I'm talking 11 days. Well, that's quite a lot of time for other infections to have occurred in the meantime. If you want to put in remedial actions, or you want to put in control measures, in 11 days, we could have a number of infections that have started to affect other children in that meantime. So time is of the essence. We also look at a situation report. So how many people, we look at those notes of the meeting. So how many people are affected at this time by date? So I would want to know, for example, how many occurred on first, second, third, fourth, and usually in my experience, that would be done in a sort of table, so you can actually see whether or not we have an escalation going on, whether it's just 2 cases, when they occurred. So we would look at the number. What I would expect to see, and what I didn't see in these IMTs when we got the notes of these meetings, was that consistency. So it might say, and I'm generalising here, it might say we have 6 cases or we have 4 cases. Then you would go to a next IMT and it would say we have 7 cases, but I don't know if these are 7 new ones, whether it's 1 new one has got better, or we've got another 2. So the way that you present the numbers of these children, we need an identifier to say it's this person, so child A, B, C, D, but we don't know if child A has got better because I don't have that commentary.
I mean, in
that
some cases, we
notes.
do see that, because for example, we went through an IMT minute for Serratia a few weeks ago, and we looked behind some of the redactions, and they were numbered S1, S2, S3 at that point.
Yeah, and that might be one that happened. But I'm talking more generally.
Right.
In the majority of cases, it was difficult to follow, and I think we have put an example of that in the report. The other thing that I didn't see from the IMTs, and don't get me, the IMTs are this is the way that we should investigate our outbreaks. We do need to look at what happens to our children, try to come up with a hypothesis. But I don't see in these, when I requested to look at the IMT notes, I didn't see an agenda that's attached to this. Now, an agenda is quite important part of the process, because it's not just about the date, the time. You want to know who is around the table. You want to know, have you got the right people? So, and in all of these investigations, what is common to myself is that you also have to have a comms person, because should this be, how do you manage if this is going to be a serious incident that you're going to look at, an adverse incident? How are we going to manage that comms? So you should always have a comms person to support you when you are looking at these. What's our message that we want to get across?
I wonder if I can ask you about a couple of bits of evidence that have come out in inquiry. So the first relates to who's at the meeting.
Yes.
There seems to have been some debate at the time, who was there and why they were there and whether they were contributing and whether it was helpful. And equally along the way, there seems to have been some discussion about a deterioration in some point over the period in the working relationships amongst people at the IMTs. Obviously, you've not spoken to the individuals, you've only read the documents. But do you detect any change in attendance, efficiency, effectiveness, tone? You pick the adjective, but any changes in the way the IMTs are operating between 15 and 19?
Yes, there is a difference in attendance. Now, in the minutes that I looked at, you'll have a list of names. Now, when you're looking at this retrospectively, you have no idea who people are, and people have moved on. So it's helpful when you're looking at on reflection to actually have what the role of that individual is in that meeting. So is it a chief operating officer? Do we have the medical director? Who is at the meeting? And we didn't get that, but I did note as we went on that there were differences of opinion into causality. This is later on in those IMTs. So there was a difference of opinion as to whether it was related to water, whether it wasn't related to water. And I can't remember at which point, but I do know that the ICD was actually removed from that post or left that post because of some of the difficulties. And that's a different conversation outside. And what I tried not to get embroiled in is that internal investigations as to what happened. But there were some changes to the ICD.
Were you told people's views on why that happened?
No.
No. Okay. One of the evidence that we've bits of evidence we've had from the lead ICD is the number of sessions involved. And I'm sure I'll be corrected in a few minutes if I get this wrong, but my recollection is that for the entirety of the period that Dr. Igster was the lead ICD, she had 5 sessions at lead ICD and 5 sessions as a consultant microbiologist. And my recollection is that by the time we get into 2018, she's basically doing all her work as lead ICD. We also had evidence that there had at various points been microbiologists with a couple of sessions with responsibilities for sectors, one of which would be sector south, including the hospital. And we'd also had evidence there would have been a lead infection control nurse for the children's hospital, one for the adult hospital, and then there would have been people operating at sector level across the whole board in the form of Ms. Devine. In terms of the size of the team for the health board and the hospital, given that you're making criticisms of how the IMTs were managed, does that team sound the right size, too small, too big, or can you not tell?
I can't really tell, but it does seem quite light for the size of the hospital for a half-time ICD for the size of the hospital, given...
No, that's an ICD for the whole health board.
Oh, for the health board, sorry, for the health board, given the complexities and actually what was going on at the moment. And we did have, or they did have, considerable concerns that were being raised at the time about the safety of the environment. Now, it did sound like, and as we've gone on and looked at some of the IMT minutes, that in some instances it did sound like a lone voice at times, but there were concerns being raised about the causality of these bloodstream infections and the impact on these children. So I do think it was probably light. Infection control nursing wise, I can't say what the rest of the team, we have one lead person, but how many is in the rest of the team? I can't say whether that was
if we as Inquiry wanted to get into the topic of, in terms of infection control doctors, whether the number of sessions allocated was appropriate. Is there any resource you're aware of in England that could teach us the equivalents in large hospitals in England?
No, I think you would probably get that from you probably get a better idea of the workload, probably from Mark Wilcox, the microbiologist, because he would be able to tell you how much workload is involved, and especially when you're investigating a series of outbreaks or potential outbreaks, that does take a considerable amount of your professional time and capacity.
I want to just pick up, we've got half an hour for lunch, on, you mentioned in the discussion about probability, that one of the factors that might put something into the probable group was there was, I think you used the word cluster. And we've heard criticisms in written form and in evidence that to some extent that your methodology as a panel, 3 of you, didn't amount much more than seeing clusters, and cluster would just make it inevitable that there was a probable link. How do you respond to that suggestion?
Given that we spent a considerable amount of time interrogating the data that we were given, and spreading that out into a timeline, it goes back to what I keep saying, it goes back to that very original time, place and person. Is there a link between these cases? And you have the same organism or a similar organism that, as far as we are aware, it is the same. And that it's based on evidence. We're not just saying we think there's a cluster. There is. It's there in black and white. There are 3 cases within this time frame.
And when you're doing your work, would you have looked at possible routes for transmission for each individual infection?
Absolutely, we would. We would have looked at whether or not there was a line, whether or not a child had been cared for elsewhere, whether or not there was a possible link with a family member who may have had an infection. We would look to see whether or not, especially whether or not symptoms suggested that there might be a gut translocation. We would look to see whether there were symptoms of that, which would potentially exclude other sources, and also other sources of infections. And I think I might have just said that about other family members who may have had an infection with something similar.
You did.
So We looked at all of those, whether or not they had an indwelling device. So one of the biggest problems that we have, of course, transmission of infection, is actually lines. So what we call an indwelling line. So either a central line, Hickman line, anything that invades the skin.
Right.
It could be a catheter. So a urinary catheter, for example, is a very good source of access into the body for an infection.
But,
So we looked at all of those.
but I suppose the point that might be made is that because of the structure of your work, the actual details in each case sit within those individual family reports,
Yes.
not in the overall report itself.
No. And I think together, taking that together with what we observed from the environment, and I'm possibly introducing something else now. So when we look, and going back to the IPC, so if we look at audit, for example, of the environment, were there other areas of the environment that potentially could have contributed to a source of infection? And we did look at whether or not any of those audits of the environment, whether they included suboptimal cleanliness, and we did see some that had excessive dust, for example. Was the integrity of the fixtures and fittings, was that robust? Could that potentially been a source of infection? Things like, and just to give you an example, a cracked sink where you get the hairline crack, that's obviously a source of potential infection. So we looked at all of that.
One thing I want to just check whether you looked at was I've been asked by one of the council is, did you look at the DMA Canyon Legionella risk assessments from 2015 and 2017 as part of your work?
I personally can't remember. I have seen them since, but I cannot personally recall seeing them. Doesn't mean that I didn't see that they weren't given to the team, but I can't remember seeing them. But I do have, having looked at those, and there is a risk assessment in there with a recommendation and action plan of what should be done. But on those plans, there is no accountable person. There is no date for when those actions should have been completed. And what bothers me the most is that there is no assurance that those actions have ever been completed. And some of those go back to 2017.
I suppose since you're here, I should try and ask you this question, which is, it's been suggested that had the infection prevention control team of the hospital known about the contents of those two reports, the 2015 one, it might have in some way changed the way they managed infections in the hospital. Do you have any thoughts on whether that seems reasonable or was wrong or what?
I would have expected some of those recommendations to have been picked up by a water safety group. I'm used to dealing with water safety group. I did ask when I spoke to the infection prevention team about minutes from the water safety group, and they said we didn't have a water safety group
For the hospital
until 2018, March 2018. But I would be expecting those. Now, while infection prevention nurses are not the experts, they do have a background working knowledge about what should happen within the environment and water, and are usually part of the water safety group. But there was an omission there that didn't happen at the time. But I think it would have had some impact on how they viewed and what they managed, how they managed their infection prevention planning and their audits.
Thank you. I wonder if we can go to bundle 6, page 984, which is part of your executive summary. And do you see how in the second paragraph it begins, we recognise that some families will be disappointed by our ability to identify links? It's the second sentence I'm interested in. This not only represents the limits of a retrospective review and the shortcomings we have described in the data we're able to access, but also highlights the fundamental challenge of identifying a specific source in all such infections. Now, I haven't asked you about whole genome sequencing because I'm very conscious that's not an area you're an expert in. I'll ask Professor Wilcox. But is it, from your perspective as a experienced infection control nurse consultant, always possible to work out whether there's a link?
No,
Why is that?
because sometimes, and I'll use this example, sometimes you can, if we had taken all the specimens as directed, as we expected them to happen, sometimes when you take that water specimen, for whatever reason, the sink's just been clean, the taps, whatever it is that's happened, we don't always collect in that specimen the bugs we are expecting to see or would like to see. We don't always collect that. That doesn't mean that it wasn't there. It just means it wasn't in that specimen. But given the absence of any other hypothesis, and there is a probability, an overwhelming probability, it's more likely to have happened than not, that is where we say that actually we can't confirm it because we haven't got that. But there is no other explanation that we are able to find at this time.
Because there are two other explanations that I'm sort of aware of in submissions by the board. One seems rather tight, and so I'll put it to you, which is that the nature of the population from which this cohort of patients came was from the nature of the population in Glasgow has a high level of urban deprivation, and there's a correlation between that and negative health outcomes. Do you see that as a factor that has any connection to this discussion?
I don't think I'm experienced enough to know that.
Okay.
However, I would say, have we tested that against other similar demographic areas where we would see the same population?
Right.
Because that's a hypothesis, but it's not a proven. We haven't proven it either way.
The other suggestion, which is a bit more diffuse, is that, and I think I'll have to ask Professor Wilcox, Professor Stevens about this, because is that could it not just be the case that what we were having here in this hospital in this period of time was a larger, but at one level not particularly surprising, increase in infections that are passed between patients or translocated from the patient's gut, and that the methodology of the case notes review is rather assuming there's an environmental link?
Translocations would show you would have other symptoms, and we'd be able to identify that.
What sort of other symptoms would you have?
Well, I'm not the paediatrician here, so
Yeah,
you'd
exactly.
probably have to ask. You'd probably have to ask Mike. But you would have raised temperatures. You'd have fever. There'd be febrile. So you would have pain potentially. So he would be able to explain that a little bit
Right.
more to you. It's not my field of expertise. But and what was the other part of the question? Sorry.
The other point was about it being an unfortunate but not necessarily unusual just increase in numbers of infections, and that you're too focused on the environment as a case notes review. It almost becomes a self-perpetuating conclusion.
Prophecy, yes. And I think given the absence, and we do have to look at what other hypotheses came forward at the time, because what you're putting to me now is since the occurrence, so since the review. But I'm not sure that a viable hypothesis was put forward, or that we could identify an alternative viable hypothesis at the time.
Okay. My final question is a bit cruel, but I'm going to ask it anyway, which is that the inquiry has set itself a question, and this is its key question 4. I'm going to read out the question, then I'm going to adjust it for you, because I think in its current form, it's definitely too cruel to ask you. So the question we set ourselves is there a link? And if so, in what way and to what extent between patient infections and identified unsafe features of the water and ventilation systems? I can't ask you that question because it seems too broad. What I propose to do is to rephrase it, is to what extent, not looking at the individual cases, but looking at it from the whole cohort, to what extent can you as a panel say there is a link between the infections in the patients in the cohort and the environment they were being treated in, in that hospital. Are you able to give us a sort of summary of your view on that topic?
What I would say is that we've probably answered that question in our report by giving the number of cases that we think are more likely to be attributed to the environment than to not. We can't confirm either way, but we cannot confirm that there is a definite link to the environment. But in terms of probability, it is more likely than not that more than, and I can't remember the number now without seeing the table, the more likely than more than half of the children were affected by the environment without any further
Well, let's just put the
evidence
table to
suggest
you,
it.
because I think it's probably not fair to get you to do it from memory. So it's page bundle 6, page 10. 1043. Yes. So do you want to do that again? This time with a bigger front to you.
I wasn't thinking that table, but yes, if you look at the text beneath the table,
Yes.
and it says where the number of cases that we were actually able to say, we were unable to determine some
I
of
think
these
it's
episodes.
two pages further on the table.
Yes. So I think
One back.
there you go. We do actually describe in that table, that's the one I think it
Table
is.
5.4.
Yes, we do actually describe in there where we think that it's most likely to have happened in those cases that there was a link to the environment versus the rest. And I think my opinion, having read anything else at the time, hasn't changed on those decisions that we made.
Thank you, Ms. Evans. Lord, that's the questions I think I have for the witness, but I wonder if we might take a few minutes to see whether anyone in the room has anything they'd like me to put to Ms. Evans.
We'll do that. Ms. Evans, what I need to do is check or allow a check to be made as to whether there's any other questions which other representatives would wish to put to you. Okay. So if I could ask you to go back to the witness room, might be 10 minutes or thereby.
Okay.
Thank you.
Thank you.
Mr. McIntosh?
I have no questions from colleagues in the room, and I have nothing else I need to ask.
Ms. Evans, apparently there are no more questions, which means that that's the end of your evidence and you're free to go. But before you do, can I thank you for your attendance this morning, but also for the work that is behind it now.
Thank you.
That includes the work on the CRNR review, but my specifics relate to the witness statement you provided. So thank you for that, which is part of your evidence, and thank you for your attendance. But as I say, you're free to go.
Thank you. Thank you.
We'll resume again at 2 o'clock.
With Professor Wilcox, yes, Lord.